Hey, good morning, everyone. This is Nancy Kelly from the New England QIN-QIO. I think we're about to get started. Thank you all for joining us today. At this time, I'd like to turn the call over to Pam Heckman, who will be our moderator today.
Thank you, Nancy. This is Pam Heckman. Good morning, everyone. I work here at the New England QIN-QIO, and I will be moderating today's webinar. Thank you for joining us for part 2 of the webinar, A New Look at Incontinence, a follow-up to our webinar that we had earlier this month on June 9th. Today we'll also hear how one of the nursing homes participating in the New England Nursing Home Quality Care Collaborative addressed their challenges with incontinence care by bringing in outside support from advanced practice RNs to provide urology services to their residents. Before we get started, I'm going to quickly review a few housekeeping items. This webinar will be recorded and the presentation will be available in a few business days. I'll provide you with details on accessing the webinar recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation. Please do not put your line on hold during this webinar. Lastly, if you find the presentation a little cut off, please use the plus or minus icon in the top of the presentation window and adjust accordingly. We will be monitoring and responding to questions and comments in chat, and we'll have time for questions at the end of the presentation. Before we get started with our program, on the next slide, I'd like to remind everyone about your monthly affinity group calls on the topics outlined on this slide. These topic-specific calls are intended to provide you with an opportunity to share, request suggestions, and/or ask questions among your peers from nursing homes around New England. We will continue to provide this forum for you as long as the group has a need and finds value in the sharing and the information. Please visit our website, which is www.healthcarefornewengland.org, to sign up to receive notifications about our future calls. Let's move on to today's program. I'm happy to once again introduce Gail Harbour. Gail is the New England QIN-QIO Nursing Home Lead for Vermont. Gail is a registered nurse and has over 35 years of experience in nursing, has extensive experience in the long-term care setting. Please welcome Gail.
Thank you, Pam, and welcome everyone. I just wanted to start by addressing a few concerns that were brought up after the first webinar. There was a question about Medicare reimbursement for rehab for urinary incontinence related to maintenance toileting programs. So for reimbursement, it needs to be a restorative program with a supporting diagnosis and contain a clear plan and goal, just as you would do with any other restorative program that you were billing for. There were some questions about interpreting avoiding diary and translating it into a successful plan, and of course this is the tricky part that you're all stuck with. But I would encourage you again to involve the resident in the toileting plan as much as possible, and in some cases extending the diary period from 3 full days to 5 full days may help you find the trend or pick up a better pattern. And again, a reminder to keep measuring the success rate of each program by reassessing the number of incontinent episodes, and do this at least a couple of weeks after the toileting plan has been initiated. There were some general questions about bowel incontinence, and Allison, our APRN presenter today, has agreed to touch on that topic with her slides. If you have a specific case to discuss, please join in at the end of the presentation. There were several comments about toileting residents with dementia, and we know how challenging this could be. I wish I had some magic answers for you, but I don't. So we're just going to share a few slides with you that you might be able to share with your LNAs or your direct caregivers, so that it might be old information, but these slides are sort of designed for you to either post a couple of them as reminders, shrink them down, use them as handouts for education on the unit as reminders. And again, keep in mind that your direct caregivers are probably the best source of approaches to patients with dementia for individualizing their care. So here is a quick look at them. You can get them from our website, and then we're going to move right into the presentations by Teresa and Allison. So the first slide just is a reminder to slow yourself down before you present yourself to, thank you, Nancy, before you present yourself to a resident with dementia. Rushing up to them in a hurried manner never works. Next slide, please. How does it work with residents with Alzheimer's? Well, the incontinence usually occurs beginning in the early mid-stage, but can be managed with just some cueing and visual reminders such as pictures on bathroom doors. Toward the later mid-stage, some physical assist or physical cueing is probably going to be more helpful. Next slide, please. It's all in the approach. You know that, but we all need to be reminded. We need to keep in mind that our direct caregivers are rushing around all day long. So again, stopping, taking a moment to get that eye-level look, engaging the resident's eyes, and of course with a big old smile. Make your request as you would an invitation. Reach out and offer physical cueing. Don't rely only on words. So please join me. That's a good way to invite someone. Just as another hint, verbal request, do you have to go to the bathroom? May get a no, even if you use the toileting words that are familiar to the resident. Toileting words vary from one culture to another. You may know the resident's vocabulary from work you did with them when they had better verbal skills, or by asking their family members. But the visuals, the sounds, the bathroom, the toilet, the running water may get a more positive result from toileting, even if the resident verbalizes to you, I don't need to go. It works the same way for us. Think about a long car trip. We may not feel we have to empty our bladders, but if we sit on the toilet, we can empty out before we get behind the wheel. At least that's our hopeful plan. Respect privacy. Lower voice tones are better heard than higher tones and are better received by the resident, who may understand the tone even more than the words. Next slide. The more steps for toileting, the more confusing and the more challenging it gets. So just keep them to a minimum and think about appropriate clothing. When you get to the bathroom, make sure that the bathroom is a comfortable environment. More is not always better. Avoid unnecessary help in the bathroom. Privacy matters. Always be prepared. Sometimes you're going to need to do incontinent care because not every toileting attempt is going to be in time. Sometimes a raised toilet seat will help. It's just too far to bend. How often do we stand face-to-face with the resident's back to the toilet? We smilingly ask, please sit, and we get a smile back, but no movement towards sitting. We gently touch their middle and smilingly repeat, please sit, and with bated breath, watch the resident get halfway to sitting, then stand up straight again. Physically, they may not need a raised seat, but they may need to feel it there for reassurance. So a higher seat may be helpful. And again, your best sources are your LMAs and CNAs. They can tell you who can get to that halfway point of sitting and then just not quite get there. Next slide, please. Address bathroom anxiety. Some alternatives. I think we know that some residents just balk about walking into that enclosed small space of the bathroom. So think about what might work better for that resident. Commode at the bedside, using the larger composite bathroom. Maybe a urinal will work. And a sign on the door directly across from the resident Remember that the resident's back is to the toilet. They're facing you and the wall in the bathroom. So sometimes a picture on that wall will help. And again, everything, unfortunately, will not work for everyone. Next slide. Actions speak louder than words. Encourage voiding by running the water, offering a drink while on the toilet. Don't expect the resident to sit there much longer than 5 minutes, and never scold. Watch for the nonverbal messages. Tugging on clothing, touching genitals, wandering aimlessly may not be that aimless. We know they may be looking for that bathroom. Do they start to frown? Do they look uncomfortable? Are they talking and then suddenly become something very silent, like their body is giving them a quick message of gotta go right now? They may move away from others to isolate themselves, or just general restlessness. If your resident cannot follow any instructions, given your best cognitive communication and expertise, and never voice or have bowel movements when toileted, talk to your team. They may not be low risk for incontinence at all. So check the documentation and the MDS about what is being coded for cognition. And do the best you can. Know that small successes are important to your residents in preventing complications related to incontinence. Thank you for this and all that you do every day. Next slide, please. I just want to quickly introduce Teresa Skinner now, who is the Vice President of Clinical Services at iCare, and Allison Gorman, who is a family practice nurse. She's a nurse practitioner with UroCare Partners.
Great. This is Teresa Skinner. I'm actually filling in today for Lucia DJ, who's our Director of Nursing at Touchpoint at Farmington, but she's unable to be with us today, so I'll do my best. Touchpoint at Farmington is a 120-bed, 4-star skilled nursing facility. Very proud of being restraint and alarm-free, with a very large memory care population of residents. Also does subacute specialty programs, cardiac and recovery services, post-surgical orthopedic care, and all other skilled nursing services. So we started really looking at incontinence management as a company for a variety of reasons, some of which Lucia has listed here as to why she was looking particularly at Farmington. They have an electronic medical record, and was sort of looking at that and some of the inconsistencies in documentation, some of the coding challenges for the MDS nurses. Also, obviously it's a CPH focus. If you have a change in incontinence and you haven't addressed the issue or put interventions in place to try to address that incontinence, always looking at skincare outcomes. And then, probably like every other nursing home, we're looking at how marketable are we? How do we build census, customer service? How do we beat our competition? So we came up with some ideas, which are our trade secrets, which I'm now giving away. So we will no longer have a market advantage on that one. But we're really looking at, if there's a change in incontinence, some of the nurses would, fill out our prefabbed assessment on urinary incontinence, and then not always know what to sort of do with that information other than a bladder diary or an incontinence management program. Wanted to get a little bit more sophisticated in what we can do with that information that we're obtaining, or how do we obtain better information. So Lucia had worked with UroCare in the past and had a positive experience with that, and asked if we could start having urology APRNs in our facilities, and of course we agreed. And so she contacted UroCare. Next slide, Nancy.
Okay, I guess I'm up. Well, good morning, everybody. My name is Alison Gorman. I'm the practice manager with UroCare. And incontinence and all urological issues in the elderly are problems very close to my heart. And that's why I came up with this practice to try to help this far-reaching complicated problem. So generally speaking, incontinence is defined as inability to control urination or defecation. But historically, incontinence has been a very, very difficult problem to study. It's very difficult to actually get a really true definition. Studies that are generally conducted are usually conducted on individuals in the community, and they don't really look at patients in hospitals or long-term care. Incontinence definitions vary in that they often ask the patient how much satisfaction or dissatisfaction their incontinence or their incontinence care gives them. This is not something that we really address in long-term care. Also, the terminology of the questions used in these studies are extremely variable. So between studies, you can't compare oranges to oranges. You're comparing oranges to apples. They don't take all of the problems that the patient is experiencing into consideration. So the problem is huge. There's the significant financial burden, which we're all very much aware of. Approximately $22 billion annually in routine care products and laundry, and this includes home and facilities combined. I'm not sure how this number was reached, but as you can see, it's significant. And this doesn't even touch on disposal costs or the environmental impact. Incontinence is the number one reason for admission to long-term care, and it is often a cause of hospitalization. It is also estimated there are more than 25 million Americans with incontinence. I think the problem is far greater due to underreporting. On an individualized level, there are significant psychological problems causing distress, isolation, depression, which can lead to underreporting. Also, significant cause of injuries and falls related to toileting, sepsis, skin breakdown, cause and complication of wounds, causes worsening of cognitive impairments. There's a significant polypharmacy, which is both cause and effect, and personal expense, with far-reaching. This is such a far-reaching, complicated problem, but we still lack an accurate diagnosis or robust evaluation, whether the patient is hospitalized, in rehab, in the doctor's office, long-term care, or in the long-term care community. Next slide, please. So just a brief touch on the types of incontinence, students and other words, which I'm sure you're all familiar with. There's the stress incontinence, which is the intermittent leakage with increased intra-abdominal pressure. Affects about 1/3 of women. It's common after menopause or with multiple births. Urgent incontinence, which is a sudden, urgent need to urinate with no access to the toilet. Causes include damage to nerves between the brain and the bladder, CDA, Alzheimer's dementia, multiple sclerosis, and UTI. You might be familiar with the Vita Care ads where it speaks to this problem. They often have the patient in the community saying, I've got to go, and they can't find a bathroom. It's kind of a poor choice of medication in the elderly, secondary to the side effects of these medications. They decrease cognition, they cause dehydration, they cause constipation. So this is a medication I try to get the patient off as quickly as possible because the side effects are worse than the benefits. And there's also mixed, which is basically symptoms of more than one type of urinary incontinence. Usually most bothersome symptoms are treated. Overflow incontinence happens when there is more urine created than the bladder can actually hold, and the bladder fails to contract or is unable to release urine due to obstruction. Causes include constipation, enlarged prostate, and medications. There's fecal incontinence, where patients are unable to control the bowel movement or gas, caused by chronic diarrhea, constipation, a neurological disorder, injury to pelvic muscles. And then there's functional, which is physical or cognitive limitations where the patient is unable to get to the bathroom. Next slide, please. So barriers to improve incontinence care, these are some things that I've come across. Incontinence is a chronic problem with very little change in management over the years. We need to get away from the one size or the one diagnosis fits all approach to incontinence. I have generally found that there is a lack of a robust evaluation. We need to individualize the evaluation across the board, and that means in all healthcare settings. Multiple times, a patient will be started on an anticholinergic medication for leaking, or they'll go to the doctor and say, oh, no, I've got this leaking problem, or I've got stress incontinence, but actually the patient has urinary retention or some incomplete bladder emptying problem. And this is where the patient really needs to have a robust evaluation to find out what's really going on, because if you are adding an anticholinergic to a patient with that type of problem, you're actually going to make the problem worse. So there's a lack of proper diagnosis. It's also undertreated, or there's an inappropriate treatment. There is poor recognition and very little staff buy-in, and this is more in long-term care. Staff don't know what to look for. An example of this is I've had a couple of patients who have had problems with uterine prolapse or hydrocele, and they've actually needed an elevated toilet seat. They're not actually looking at what's going on in the bathroom. There's a lack of interest, or there's a resignation mindset. All the problems patients got incontinence, so there's really not very much we can do about it. So we just keep on doing what we've been doing. There's inaccurate or inadequate documentation. For example, licensed staff should be checking in when patients have diarrhea. They're more likely to have a urinary tract infection with enteral bacteria contamination, like with diarrhea, for example. And that's more likely to come with bowel incontinence. So we should be checking for new incontinence, and we should be checking hygiene on independent patients because we really have to know periodically what's going on with them. The health trajectory of the patients in the long-term care setting is generally in a negative way. So at some point they are going to be needing help. So you need to find out when that is, or watch for that, and then act appropriately. We have a very task-oriented approach to care, and often, this is across the board, caregivers are resistant to a new approach, that they're resistant to change. There are also thin staffing numbers and or float staff who don't know the patients, and so these all contribute to the barriers. So the basic vision, the vision for a new type of care. So facilities today have been using a very basic tool for identifying urinary incontinence. And it usually involves asking the question, is the patient continent? And some of the data collected in obtaining this information is the bladder diary. Bladder diaries are very difficult to fill in. They're very overwhelming. You see a chart with 1 hour for each 24-hour time slot, and everybody feels that they have to fill in every single slot. They don't. Basically, the caregiver should be taking this tool with them when the patient is on, an identified patient is on the bladder diary, and every time they go to evaluate that patient, then at that particular time, whether it's 2 o'clock in the morning, 7 o'clock in the morning, 3 in the afternoon, 11 o'clock at night, was the patient continent at that time, yes or no? Or were you able to take them to the bathroom? And that is the basic premise for filling in those bladder diaries. And then you should get like 3 days worth of data. They don't have to be back to back. It can be once a week, especially when you've got a new patient in the facility. All bets are off. The patient's trying to get accustomed to their new surroundings. You don't really know what is what with the patient. So I would always suggest starting that like maybe do it initially and then repeat it maybe a few weeks later or a month later, and that will give you more accurate data. So anyway, so you ask the patient, you find out is the patient continent, and then a checkbox, yes or no. Yes, they get a brief and incontinent care, and then no, they get taunted. But due to the prevalence of incontinence in the elderly, a more comprehensive evaluation is required. So improving continence or preventing incontinence in the bladder and bowels is a significant way to improve the quality of life for residents and to decrease morbidity and save healthcare dollars. So the APRN can help really provide a comprehensive evaluation of the patient. Urinary incontinence is a symptom and results from multiple interacting factors. Therefore, patients need a more holistic evaluation, a physical exam, bladder scan, and also talking with the hands-on caregivers and nursing to really get a good look from all aspects as to what is going on with the patient. And this way we can come up with a diagnosis. So what is going on with the patient? Is it urinary retention? Is it incomplete bladder emptying? Does the patient have a shy bladder? Are they depressed? Is it a functional issue? So when you've formulated an appropriate and practical plan of care, then you can follow up and see what is going on with the patient, what works, do you need to try something else, are there other issues which are coming up because of this. It's also very important to identify comorbid issues such as retention, UTI, constipation, especially with diabetes. Poorly controlled diabetes really does need to be addressed. You need to look at dietary intake, such as does the patient take a lot of caffeine? Do they like sodas? Do they like a lot of coffee? I know that we don't normally give patients caffeinated drinks, but also cranberry is a double-edged sword. Cranberry, a lot of people feel, is very helpful to the bladder. Actually, it can cause bladder irritation. It's good if the patient is a chronic UTI sufferer, but if it's incontinence, I would not automatically give cranberry because it is actually a bladder irritant. Patient also requires periodic follow-up to avoid risk of predictable comorbidities, and you need to support and change the plan of care as necessary. As a nurse practitioner, I also like to be a resource for the facilities we serve. We want to troubleshoot problems, make suggestions, and provide in-servicing. And we also need to educate the patient as far as we can. If they are alert and oriented, we need to talk about what we're actually going to do for them. And then also I refer out to urology of all the things that I have tried fail. For example, patients with recurring UTIs, if that keeps going on, they need to go to urology for a cystoscopy if it is appropriate. A footnote to this is having a bladder scan in the facility is a superb tool that nursing can use on a daily basis for collecting data in the long-term care facility. As a nurse practitioner, I think of it as the sixth vital sign. We have temperature, pulse, respiration, blood pressure. We added the SpO2, the oxygen saturation, as the fifth vital sign. So I like to think of this as the sixth. So it should be used when there's anytime there's a change of condition, especially in mental status. I have an example of a restless hospice patient that I've been to see, or have got for all patients that exist in my practice, and they've gone on to hospice. And there's other patients restless, and they keep going up and up and up on the medication. I come and I check the patient now has urinary retention because of the opioids the patient is receiving for their symptoms. You can obtain a refurbished blood scanner for approximately $2,500. Up to the Rolls-Royce types, which practically mow the lawn and do lots of other things, up to $12,000. So check online. And anybody who's a grant writer, I've known several facilities where they've been able to get a grant written. Next slide, please. Just touching on fecal incontinence. This is a whole subject by itself, but these individuals also require a history and physical to determine the underlying cause before planned care can be determined. Causes can include chronic diarrhea through their lives, chronic constipation, inadequate fibre and water in the diet, diabetes, CPA, neurological disorders, psychiatric disorders, impaired cognition, polypharmacy, That's a huge one. Changes in diet, changes in mobility, and this is strongly linked to UTI. You've got to keep a watch for changes in continence or changes in bowel pattern, and we have to act on those as soon as possible. Next slide, please. So some practical methods for treatment. The bladder is a trainable organ. It really is. People look at me when I say this, but it really does. If you get patients on a schedule, it's amazing how well it will help keep the patients alive. Especially the patients who are cognitively impaired but they're ambulatory, I find don't ask the patient, just take the patient. It was a very nice slide that we saw earlier, the gentle approach, the come with me approach. If you ask the patient, invariably they will say no. But if you just jolly them along and bring them along with you, they will come. Prompting patients to toilet, especially those who are independent in care, just check in with them. Check in to make sure, you start seeing changes in their cleanliness or their clothing, and pick up on those points and start paying more attention. We have to avoid and treat constipation. The bladder and the bowels are best friends. Constipation is very often responsible for increased urinary retention, incomplete bowel emptying, and urinary incontinence. We have to pay attention to hydrating our patients. We have to be careful with patients who have congestive heart failure. We don't want to overhydrate them and tip the balance and put them into failure, but the patients need to be appropriately hydrated. We need to observe some new symptoms. UTIs can trigger new or increased urinary incontinence. Review medications. I always do this. We need to reduce polypharmacy as we are able, especially medications with urinary tract side effects, sedating meds, hypnotics, and avoid bladder irritants, the cranberry soda, caffeine, smoking, spice foods that we talked about earlier. And something that I like to do when appropriate is adding low-dose estrogen for the female incontinence. It plumps up atrophied tissues. And the topical medication works well. Estrone, or the topical estrogen, it's non-systemic, and there's a very, very low chance of increasing cancer or in patients who have had cancer in the past. And then control of diabetes. This is so important because increased blood sugar causes increased diuresis and dehydration and spilling of glucose into the urinal tract. So the spikes in glucose, it provides food for the bacteria that's already present in the postmenopausal female urinary tract. Next slide, please. This is huge. Hiring quality nurses and nurse assistants. Nurse assistants provide the lion's share of continence care, and they provide the foundation of all hands-on care that we provide for our patients. But they have the least amount of education. So we need people who are interested and motivated. I was once in charge of hiring nurse assistants for a facility that I was working at as a registered nurse. And my modus operandum was a 5-step approach to hiring. So I would collect my applications and I would go over them. Now, if those applications were written in crayon or they were incomplete, or the English was poor, or the language was poor, and right away it was thank you but no thank you, because this is a very important part of communication. If they can't communicate when they are applying for a job, which is important to them, it's their bread and butter, then they're not going to be good communicators with other team members, with patients, with documentation. So it was thank you but no thank you. Then I would call the people that I would select. The phone calls, they pick up the phone, they've got good telephone manners, they're polite, they're excited to hear from you. Then I would invite them to come to interview. Then as I'm meeting the person, I like them to be on time, I like them to be well presented. They don't have to be wearing an interview suit, but certainly no jeans, no piercings, no those awful ear sorts of things that they wear these days. None of that. We're dealing with elderly people who want to have people that they recognise. So if I meet them and then they're pleasant, I'm greeting them and I'm walking and talking them down to the evaluation area or the interview area. How did you get here? Was it a good drive? Did you find us okay? And just I'm assessing this person for, do they have good conversation skills? Are they pleasant? They might be a little bit nervous. That's actually a good thing. And then we'll sit down and we'll talk. And I usually start off by saying, so, why did you apply for this job? And there better be something in what they say about them really liking looking after patients. That they want to go to nursing school, or their mother was in healthcare and they think it's a really cool thing, or they like elderly, or they've looked after elderly family members, or they just really feel that elders really need, really good, significantly well thought out and implemented care, something, anything. Or I might, prompt them a little bit. I've been in nursing for 30 years. I love it. My mother was a nurse, and just so I get an appropriate kind of feel that they really want to do this job. And then I tour them. And if they're touring and they're smiling at people and they're saying hello to patients, they're saying hello to other staff members, I take them back and I hire them on the spot. And they've got to have a check for all of those 5 points. So we need to build, develop and value a quality team. They are vital in providing quality care. We need to support nursing with education, practical direction, practical care tips, and praise for jobs well done and successes demonstrated. We need to encourage supervision of nurse assistants, check their work periodically, check documentation, and most of all, check in with patients and their families. This is always known to improve patient satisfaction. And generally, improve communication. Reports and documentations need to be complete, meaningful, and useful. Act right away when there are changes noted. And we need to, when we see patients with liquid stool, when assessing for frequent UTIs, we've got to keep stool off their urethral meatus. Make sure staff know what the norms are. I can't tell you how many patients that I go to evaluate for recurrent UTI and they've got liquid stool. If you don't deal with that, they're going to keep getting those enteral UTIs. Next slide, please. So I have a few case studies here, and these are real-life patients that I've come across. Number one is an 82-year-old female with advanced dementia, independently ambulatory and self-toileted, continence, bowel and bladder, excellent hygiene, excellent grooming, and she actually was a retired librarian, never married, no children. Suddenly developed bowel incontinence in the night time, waking her from a sound sleep. Everybody was uproar. The staff said she would go into the bathroom was a total mess, the patient was mortified, the roommate just was beside herself, and the staff just had to clean her up. So she'd had a small weight loss, and because of this, dietary had added a protein shake at bedtime. And so what had happened is that she had the protein shake, and that's what was causing her to defecate very largely through the night. So all we did was change the time of protein shake, and the continence was restored. Number two is 42-year-old male with schizoaffective disorder with advanced age, asked to be evaluated for urinary incontinence. The day that I visited, the patient's sister happened to be there, and she said, I need to take him out to a movie now and then, or home to see family, or just down to buy some candy or an ice cream or something. And he would just, all of a sudden, they were taken to the bathroom before we left, and then he would just pee in the car or pee at the movie theatre. And she said it was terrible. I just couldn't take him out. Anyway, when I evaluated this chap, he actually turned out to have urinary retention. My bladder scanner was reading greater than 1,000. I straight cast him. And then when I looked at his medication, I realised that he's on a lot of antipsychotics. So I talked with psych, we added Flomax, and also the APRN in the facility had added oxybutynin. So we stopped the oxybutynin, we added Flomax, switched around from his meds, and now he is continent, and his daughter can take him out, and his sister can take him out, and she's just thrilled. It really improved his sentiment, quality of life. And then a third patient, a 39-year-old male with advanced MS and urinary incontinence, bladder incontinence, suddenly developed urinary retention. And his problem was constipation. Basically, he had a bowel movement every day, but he just was not emptying enough. So we really aggressively maintained bowel emptying with, he was on like 3 or 4 different purgatives, but I added a weekly cheap enema, and that helped keep him flying right. And then the fourth patient that Lucia Detail was actually going to talk about was an 80-year-old lady with forgetfulness and new onset dementia, but still quite able to self-toilet, self-care, started noticing that she had soiled clothing. But with prompting toileting, she was also able to maintain continence. This lady had also had some falls, which also resolved with prompted toileting. So that is the end of my presentation. Thank you very much for attending, and I can entertain any questions. There's another slide here. So I think Lucia was going to address this, but Eurocare.
Yeah, I can talk a little bit about this. Lucia filled me in. This is Teresa.
Okay, very good.
Great.
Thank you very much.
I think when Lucia first decided to have the Eurocare APRNs come to the facility, I think those of you who are in long-term care, when we get a good idea, we just think the whole world is going to understand it and go with us, and then we're kind of concerned when they don't immediately see the wisdom of our ways. So I think Lucia had some of the same findings when she first introduced this concept, and some of them were a little bit surprising. She didn't expect to have resistance from medical staff. I think the thought was from some of the physicians that would be that this was just going to add, another layer of practitioner to the facility, the APRNs were only going to prescribe more medications, and the residents were already on enough medications. So Lucia had Eurocare come in and present at the medical staff meeting. And that way they could hear directly from Allison and Rosa what the philosophy of the company is, and it's really about an appropriate diagnosis and an individualized treatment plan, and not necessarily about just adding another medication. So that was a crucial piece to having this program be successful, with buy-in from the physicians, because they were going to be the ones who would have to order the consults and then also would get the recommendations for approval. So she started off with the medical staff meeting. Next, the Eurocare APRNs came in and provided in-servicing for the managers and the direct care staff, trying to enhance awareness and really talking to the staff about how this is not going to be just another person coming in, giving them a list of things to do for the residents, but somebody who's going to come in and talk to them about the resident, what the staff knows about the resident, what types of interventions they've tried, what's worked, what hasn't worked, and also kind of providing some education around the different types of incontinence and some different treatment modalities, and really getting the staff to see that this is going to be an adjunct to what they're doing, that this is also going to make their life easier if we can maintain continence in some of our residents. So kind of brought in that in-servicing to get staff buy into this process. Another aspect of what they did at the facility was to involve the MDS coordinators. Eurocare asked for the CASPER reports, and off of those they help identify any residents who already have a change in incontinence or are at risk for a change in incontinence. And then the interventions that the APRNs come up with can then be rolled into a better resident care plan, a more personalized resident care plan. Also, sometimes the MDS people, when they're doing the quarterly MDS, are unfortunately the first person to realize that there's been a change in incontinence status. CNAs have probably noticed it, may have not told somebody about it, but they've been documenting. So they tend to, as a review of the CNA documentation, it can also help us identify residents who are appropriate to be seen. Also incorporated the rehab department. kind of solidifying the use of some of the treatment modalities in rehab, the e-stim and things, to incontinence management. Some of these residents are already on program. Maybe they're being seen by occupational therapy, and part of what's being worked on is toileting, making sure that the whole team that's treating this person has the same information, kind of contributing to the plan of care, and that we're all following the plan of care. And then the other thing that Lucia talks about is celebrating outcomes, no matter how small. You know, incontinence management can seem to be this sort of overwhelming thing, and in contrast to some other diseases where we can see a cure, especially with the dementia population, we may not see a cure, but that's not how we celebrate successes. It may be that they're going to continue to be incontinent, but instead of 5 times a day, we can get them to be incontinent 4 times a day. That's a success. Or they had, you know, a UTI every other month, and now we've gotten it down to only 2 UTIs in a year. And that's some of the things that the facility does to track successes, you know, monitoring UTIs, monitoring incontinence on the quality measures. Also, one of the things that they've looked at as a measure of success is falls. Had some good success with decreasing falls by improving continence management. So celebrate successes, no matter how small. And these are our contact numbers in case you want to contact either one of us or Lucia. I can quickly give you her contact information. She's Lucia, DKLUCIADIKE, and she's at Touchpoints at Farmington.
All right. Thank you so much, Teresa and Allison, for your presentation. This was very interesting. We are open to take questions, and right now I do see one in the chat. Allison, could you please describe your incontinence assessment and explain how it differs from the assessment done by a unit nurse?
Yes, absolutely. The unit nurse basically will either find out if the patient is continent or not, either from the diary or from the transfer documentation if the patient is a new admit, or it's been noted when the nurse assistants are doing their documentation. And then I don't know even if they report it to the house APRN or to the attending physician, but really it is a change, it is a significant change in condition, so it really, really should be addressed. When I am asked to see the patient, or when I'm brought into the patient, I always ask what the chief complaint is. You know, is it for incontinence? Is it because the patient's falling? They've had frequent UTIs. They've had a history of the UTI. There are lots of different reasons. And then basically I review the notes and make sure that I just make myself very familiar with the patient's history. If the patient's been a long-term patient for years, often I don't know why the patient first came in to the facility, but I like to have an idea of how the patient has been and then get some kind of idea of their decline or what has happened to them up to this point, up until our meeting. I review the medications, I review all of their allergies, and look at their vital signs and see if there's been any recent changes in their care. So have they recently had a UTI? I also look at the labs. I have to take this is a very, very important piece. It's lab interpretation. Look at kidney function, and I look at how many UTIs they've had, when they've had them, and what the causative organism is. And this is very significant because it gives you an idea. If it's an enteral organism, E. coli, we're all familiar with that. Then I know, okay, this could be a hygiene issue. This could be a diarrhea issue. This could, it starts to narrow where I'm looking at, and that starts to narrow the target a bit for me. So I collect all of that data first, and then I will go and I'll see the patient, and I do a head-to-toe assessment, complete holistic evaluation, basically how the patient looks. Are they looking ill? Are they chronically ill? Do they look well? You go through all of the systems. It's a 10-point system, including neurological, cardiopulmonary, abdominal, musculoskeletal, what their mobility is like, what are they currently using, are they currently incontinent, are they incontinent, what do they use, how is that managed, do they have a Foley, why do they have a Foley, have they tried to get Foley out, you know, all of this information, it's all really important. And so I evaluate the patient, and I always do a pelvic exam or a rectal exam. It's incredible to me how I look through the patient's physical history from previous providers, and it's always the first. So quite often, these patients, even though they're getting a physical exam every year, initially, or 30, 60, or 90 days, and they never get a pelvic or rectal exam. And I find foreign bodies, I find pessaries that nobody knew they were there. They got lost because of poor documentation. It's amazing what is actually found. And then I speak with the staff. I basically talk to the nurses. Unfortunately, nurses don't really know very much about what's going on with the patient as far as continence is concerned. The real source of my information usually comes from the hands-on caregiver, from the nurse assistants. So they know exactly what is going on, and I just always praise them for their care whenever I say thank you, that is really useful information. Anything else that you can add, you know, and I also ask, how does the patient hydrate? Are they good at taking their fluids? What sort of diet do they have? Do you have to feed them? So, you know, all of this information, and then I write a very comprehensive note. I formulate my information, I come up with a diagnosis, and I write a plan of care. And then I follow up with the patient. Yeah, I follow up with the patient. Now, if the patient is, if I implement the plan of care, I usually follow up with the patient in 1 month, and then I'll follow the patient if they're stable and fairly young. By fairly young, I mean sort of like in their 70s, and they look stable, nothing much has really been going on, but this is the plan of care. Then I'll see them again in 3 months, and then every patient, regardless, I'll see every 6 months. Unless, of course, it's a psychiatric patient who has incontinence due to psychological issues, but they're not having UTIs or any incomplete bladder emptying or retention issues, which can be caused by their medications. I'll just say, you know, just look out for these, check that there's no change. Then I'll see those patients annually. And of course, I can always be asked to come back and see a patient if something comes up. So that's basic difference.
Thank you so much. That was very comprehensive and interesting, too. There's another question in chat. One of our listeners wrote that she's found that most patients with a UTI have confusion. Why does it affect mental status? If you could.
Sure, absolutely. Mental state, because these patients are so frail and fragile, and we tend to get that because we see them every day. They're breathing, they're eating, everything's going along. And this is what, you know, what I'm speaking to when patients have, you know, when we get very task-oriented when it comes to, you know, we see them, they're there, this is what we do, and then all of a sudden they become confused. And they think that this is, you know, like a big change. And it is, but they often become confused because their body is trying to fight an infection. And elders fight infection very differently from a younger person. Like if you look at a baby, they'll go from a normal temperature to 104, and they'll still be babbling and eating and drinking, and all they've got are flushed cheeks. The elder will get an infection, and their body's trying to fight it, and you may not see more subtle signs first. And then what you'll see is change in their mental status. And the change in mental status is usually evidenced by they're more sleepy, they can't hold their head up, they won't eat and drink as well. And, you know, these are, can often be subtle signs, and then all of a sudden say, oh, the patient's got a UTI. But you still need to look very, very carefully. And what I'll say is when you think there's mental status changes, the first thing you should do is put the patient, as long as the patient isn't looking septic, which is really important. So your vital signs, which should be done by the licensed nurse, don't send the nurse's aide down there. So, oh yeah, they look a bit different, go down there and check a set of vital signs. The nurse has to get in there and do manual vital signs. Blood pressure, heart rate, temperature. If they can't close them out, it needs to be done rectally. You've got to get an accurate temperature, oxygen saturation, and then if the temperature, and quite often in a septic patient, the temperature will be low, not high. They'll have a subnormal temperature. You may see that shaking chill. That is significant. That needs to be called into a doctor immediately. The patient may need to be hospitalized or need IVs at that point. But if the patient is stable and they have a mental status change, I would recommend putting the patient on the 72-hour UTI tracking pathway. And nursing can do this. They don't need an order, at least in some buildings. I don't know. You may require it. I don't know, but check with your medical director. And so you're going to hydrate the patient. You're going to check their vital signs every shift. And if there are changes, then obviously those need to be reported. But really, we should be following the McGear's criteria. And they have loosened up a little bit in the last couple of years to incorporate the patients with cognitive problems. So you have the demented patient with a change in mental status. You're watching them for 3 days. You're checking their vital signs. You're pushing fluids. And also, I would say, even go as far as starting IV hydration, which will also get them over the hump, because quite often those mental status changes will be due to the patient's poor hydration or underhydration. And notice that I don't use the word dehydration, because we don't want to see that anywhere in the documentation, because that is a trigger for the state. So underhydration, get those fluids into the patient, and then if you're noticing hematuria, if you're noticing that the patient is really not improving in those 3 days, then send your urine and then treat the sensitivity appropriately. Because what I'm also seeing is that the doctor, the nurse practitioner is seeing these changes, putting the patient on an antibiotic, and you're flying blind because you don't know what you're treating, and then they send the CNS, and they come back with a different sensitivity, and then they change the antibiotic. So that all of that poor treatment is also adding to the resistance to antibiotics. And in about 10 years, we're going to be at the creek without a paddle, because there's nothing new coming down the pipe. So that is what I read, and this is what I try to explain, even on an individual basis, to nurse practitioners, doctors, to please really look at this problem appropriately.
All right. Thank you very much for that.
You're welcome.
Are there any other questions? People are able to use the phone. Press #6 to unmute your line. And if there are no other questions, then you can call in and interrupt me if you need to, but this will just be to remind you that there's an evaluation that will automatically pop up on your computer, and if you can fill that out, we would greatly appreciate it. If you don't have time now to fill it out, you should receive an email tomorrow morning with a link to the evaluation, as well as a link to the event page. And the website is now listed in our chat. The PowerPoint presentation is posted on our website at www.healthcareforneweengland.org/providers/nursing home, and you'll find it under tools there. This recording and a transcript will also be added to our website as soon as it's available. I want to thank all of you for tuning in today. I especially want to thank Teresa and Allison for a wonderful presentation, and Gail for bringing forward some more information from her wonderful program on June 9th. So without further ado, I'll terminate today's call and look forward to seeing you again on our webinar that you will receive an announcement for shortly. Will be in September. Thank you.
Thank you.